morning. It's a big honor to be here and to see you. There are some big gods of orthopedics. Hi, Massimo. Massimo is one of my biggest person, what I saw. And the reason I would be better orthopedic surgeon is that I started performing triathlon also. So he's the triathlon performance. So I started to do the triathlon to be better orthosurgeon. So hope in a while it'll be. So let's talk about myelography. Just to know, I'm standard ortho neurosurgeon, so I'm not a radiologist, and there's my perspective how I perform with those neuro cases. So I think there are some errors, but we know that this is what is suitable for me and for my practice and how I use this technique. So myelography is putting contrast medium into the spine channel. So directly it's intrathecal application of non-ionic contrast medium. We can use two ways of application, so cranial and caudal. We will speak in the future about each application. There is different approach than Filippo has. For myelor studies, I put all those cases under general anesthesia. All of them are intubated and all of them are ventilated. I use pressure control or volume control ventilation, and for those cases I don't use apnea, but for some thoracic studies there is better to achieve apnea. I think there's some lecture about apnea or not. So there's a team how to perform apnea, so everything is up to you and your machine. So it's not a big deal to do it, and the quality of images is much better with apnea. There are no moving artifacts, and you are much more comfortable with the result. So, as I said, there are two spots of application. The first one is cranial puncture. We use atlanto-occipital region, and the second is caudal. And caudal puncture is L6 or L7 or L7S1. L7S1 is better, but usually, to be honest, sometimes it's easier to go a little bit higher about fatty animals, or if they are not in the perfect condition. So sometimes I use L6, L7. I think it's not an error, but the right spot to application for caudal puncture is L7S1. What I use for those studies is this type of contrast medium. Standard is 300 milligrams per milliliter, and usually I a little bit dilute it because I need a higher volume of higher volume of contrast or of the medium what I am applicating. On the right, this is a spinal needle. Standardly, I use this orange needle for 80% of my cases. For bigger dogs, I use black one. I don't know the gauge, but those two are my standard needles for application. And there are some amounts of contrast, usually 0.3 per kilo. I don't use it. I use it standard volume for me, so small animals, usually 3 to 5 mils, medium 8 to 10, high or more heavier, usually 15, 20. It depends on the location, what I'm looking for. And as I said, usually I a little bit dilute it. So I count the normal value or normal volume of the contrast medium and then put some fluid in it to dilute it. So caudal puncture, for all punctures, I use some anatomical landmarks. So those anatomical landmarks here are iliac wings here, and the tip of L7 here, and I apply the finger or my fingers on it, and then I will apply it. So let's see the video. No. Crazy stuff. It's not working. Now, yeah. So you can see how I'm holding the bones, and then the application of the needle is usually perpendicular to the spine. So it's not very big problem to get in. Usually you can feel some special resistance you are going through. So you just go through the skin and the muscles, and when you are going through the spine, not the spine, but the spinal channel, you can feel some small resistance, and then you are in. So that's not a big problem to get in. So there are other videos of my application. So usually I just palpate the last spinal process and just easily go in. To be honest, sometimes it's not so easy, and you are trying to get the right spot, and you are moving with your needle a little bit in this direction, but video needs the best projection, so this was the first attempt. Yeah. But to be honest, sometimes there is a lot of bad words around, because sometimes it's not so easy. Yeah. So, and I just want to be most interactive as I could. So I perform fluoro during application. So you can see how is it looking on the fluoro during application of the contrast medium to this dog. You can see on the right picture how the myelo is going. So this was video just for this presentation, because to be honest, I don't perform myelo standardly on fluoro. For me, it's much more easy to get in, just palpate where I am and put the needle in. But here you can see some kind of application via fluoro assistance. To be honest, with this machine and this setup, it's not very comfortable, but I hope in the future there will be some change of setup and it will be much more suitable, and we will be more confident to do that. But you can see, for me, the biggest problem is to do something on the table and to see to the monitor up. So it's not easy to get in this way, but it's possible. Yeah, so there are some perspectives from the gantry, inside and outside, how to see how we are performing this. Cranial puncture, the same. We are using some anatomical landmarks. So on cranial puncture, we use Ala Atlantis at the anatomical landmark here. External protuberance occipitalis externa here. So those three landmarks can navigate us. And if we do that, the puncture is not a big problem to go in. So you can see that I just go through the skin and the muscles, touch the bone, and there is a time to be very patient, and your movement of the needle should be very, very delicate, but it's not a problem to go in. For all cases, I collect CSF. Sometimes I send it to the lab, sometimes I throw it up because we don't use it, but before contrast medium application, it's necessary to have CSF. And the similar application, so if your needle is inside and you take out some amount of fluid, then you can apply the contrast medium. For cranial puncture, what is my recommendation is that the head should be lifted up, and the gravity of the animal allows to go the contrast medium to the spinal channel, not to the head. Yeah. And after application, I hold the animal by hand for the head, and the standard position for 1 to 2 minutes is this. The big problem with 40, 50 kilos animals, it's strange, but it helps much. And for those cranial puncture contrast studies, it's necessary to be a little bit patient and wait till the medium is in the channel. So I perform those images usually after 2 minutes after application. So this is the same, and one trick of the application here is you have to move the head towards the chest, so that there is a big flexion, and then you can open the space for application. So this is other case of fluoromyelography. So you can see how the contrast medium is going through the vertebral channel, and how nice pictures could be. For me, this is something what is time consuming. It doesn't make sense for some better diagnostic, but for some reason, if you are in troubles with application or catching the spot, the fluoro should be a solution how to perform. So this is the first case. This was, I think, 7 years Dutch hound with acute tetraparesis. It was 1 or 2 days. He was paretic. You can see nice Czech girl, and there were less spinal reflexes on the 4 legs. So what you will do with this case? Some idea? We are here for CT, so we perform plain CT. Can you see some kind of anomaly on this vertebral channel? No? Yeah, it was not very nice to interpret this case on the plain survey native CT image. But there are, if you know which place you will going to recognize, there are some small pieces of something, and this is 3, 4, 5 here. In this case, the intervertebral space is a little bit narrow, but it's nothing. So the plain native study for diagnosis of this case wasn't useful. So we performed myelo, and something changed. So you can see on this picture there is a huge ventral compression. It's C5, C6, and you can see it's a little bit more on the right side, but for those cases where the ventral compression is, we usually perform ventral slots. So other projections or other parts of those imaging, there is a big hole here, so that it's extruded this material which we have to put it out surgically. So this is, I think, 6-7 days after surgery. Not perfect, but it was when she was getting home and starting her physio and other therapy. So other case, this was, I think, 7-year-old mixed breed, like Dutch Hound male dog, and he was hemiparetic, and there are some other images. So the fluoro, I just want to compare fluoro and myelo. You can see the same changes or the same abnormalities on the fluoro, on the myelo. So, okay, in this case, we could have a good diagnosis after fluoro, but to be honest, I want all images in all axes to check it, how is it looking. So the fluoro in this case is something just for quick orientation about the problem, but it's not perfect diagnostic tool for tiny intervertebral masses or disc protrusion, extrusion or something like that. So you can see there is very lateralized disc extrusion. It was TH12, TH13 disc extrusion. So this was also surgical case. And now what you can see here, and thanks to Ilaria for helping with some changing my images, it's a new software, and I have to say I'm really waiting for new software in my machine. So you can see that on the right side there is reverse colored image. So what was black is white, and what was white is black. And there is a very nice part of disc extrusion on the right side. There is a huge intervertebral mass, and the similar is here. And because I love this new version of the software, there is a nice video. How does it work? So you can see the myelo, and this on the right side there is a right-sided compression, and you can see it was more cranial, and when we moved a little bit more caudal, there was narrowing of the disc extrusion. You can see how the spine is going upstairs, and there is something what is in the spine channel, and now the spine is getting back to the bottom of the channel. And the third case of the myelo, it was 10 or 11-year-old dog. You can see there is also some discus spondylitis, but it wasn't that case of the problem. The problem was also the ventral compression of the spine channel, and this dog was hemiparetic, but was paretic, and you can see the large mass here. So also ventral compression, and it's a little bit also right-sided. So the standard myelo, you can see this part, which is filled with some kind of extruded material. Also, it was surgical case. Other axis, so still the same dog with a huge extrusion here, and you can see how big ventral compression is here. Thank you. There is QR code with my email or my phone number, so if you want to contact me, you can scan it. Some questions?
Yeah.
This one?
Okay. So, okay. Thank you for your presentation. I'm really interesting about, because 20 years ago I started with myelography and neurosurgery, and then I get off because so the neurologists in Italy stress the importance of MRI, and so I can go back and I can restart my my activity in neurosurgery. It's possible.
It is.
It is?
It is.
Okay. Yeah, it's a practical question. So, do you think that there are some limits in some clinical cases? I need to converge in specific cases? This is my practical question. Thank you.
So for sure, who is able to use MRI for those cases? Okay, it's solution. I'm not the neurologist, I'm just a surgeon. So in my point of view, I need to know if this case is surgical case or not. And my standard view for this case, to do standard neuro exam, localize the lesion, to know what's going or where should I look for, to do CT, standard plane survey, then take CSF, then do myelo, and to know. And after that, the myelo is not clear for me, so I couldn't see some big compression. I have to think something more, but I don't know, 80% of my cases, which if I'm looking for some disc disease, I'm really sure that I will find it. So it's easy to go in, to have a diagnosis, and then to do the surgery. And for surgical reason or for surgical planning, you have to know where you are going. So it's mandatory. Yeah.
Thank you. Yeah.
So I agree. Also, based on my experience that I have also in the MRI, you can see if it's surgical or not. You can see the compression, or you can see a neoplasia. What you cannot see is an ischemic myelopathy or a meningomyelitis. So, as I was telling before, like it's a very nice tool if you're going to go to surgery. It's efficient. With a fluoroscopy, I prefer it and enhanced, like I forced my colleagues to use it for their team, the fluoroscopy, in order to avoid the epidural myelography. That's a failure, so you can miss something. So, and it's more easy because once you have the fluoroscopy, it's easy for your team to work on that. So do the joint tap, do the myelography with the fluoro. So if you're not the experienced guy there, all the other them feel more comfortable using the guided technique. And you can rule out in a few minutes if it's surgical or not. So if it's like ischemic or if it's inflammatory, you should do the CSF tap and then you rule out the inflammatory and then you go to ischemic myelopathy. So in my opinion, like in stifle and for the vertebral column is a very effective tool and cost. It doesn't cost that much. So money and time, you gain a lot. Thank you.
Thank you. Thank you.
You have, okay.
Apologies for my ignorance. Just before you presented the cases, there was a fluoroscopy showing the contrast medium, ascending up, and then suddenly there was a channel running down ventrally. I just wondered what that was.
Some vein or artery. So there was some. It was an error, but it's something what sometimes could happen, and there is some ventrospinal artery or vein, which I just put the medium in, but it's not a problem.
Well, at the moment there's, let's say, 50% of spinal cases that are brachycephalic dogs, right? And in my opinion, the brachycephalics are very hard to hit the point inside the spinal tap, or I mean cerebrospinal tap and the lumbar one. Do you have any comment on that? Just if they are more difficult or not?
Okay, so I've got a lot of Frenchies with some spinal disease. Sometimes it's strange to go in because for the cranial tap, for Frenchies, everything is moved somewhere because they are. Yeah, sometimes it's not easy, but I think in those cases, the cranial tap is easier than caudal. Their channels are quite narrow, and sometimes it's not on the first tap to go in. Yeah, but fluoro could be the solution how to improve your images, or how you are able to improve get in. But the fluoro sometimes, okay, it improves something, but you have to know what you are doing and how you are moving with your needle. I don't think the fluoro solves other problems with missing the place or right spot of the application. So it could improve something, where you are, but if you have some application problems without fluoro, you can have them with fluoro also. So I didn't tell it during the presentation, but also here it's good tip and trick to a little bit twist the animal over some padding, or put the front legs under the abdomen, hind legs under the abdomen. So the spine is not in this position, but in this position, and it's more nature for your hand if you are moving in this direction. So, can you hold it? if this the body and here are the vertebral spinosus processes, so it's easier to go this way than this way. So it helps a little bit, and you can open the intervertebral space a little bit. So yeah, this is small trick how to be better. I'm a left-hander, so I use the orientation head here and belly here. So that's other.
So that was a very nice question. So usually what we suggest is like to do a plain CT, so brachycephalic. You can see the mineral material in the vertebral canal, so you don't do intravenous contrast medium or myelography. So 80% of cases, if it's surgical, you can see it in the plane. So we stop the scan there. Or when it's an acute nucleus pulposus extrusion, what we see commonly in MRI is that you see the hemorrhagic component is going the epidural space and extending, so you have like the contusion of the myelopathy. And it's not surgical, so sometimes we have to see how much of this material, hemorrhagic material, and this material is compressing, and the surgeon, you don't have the same opinion. A few of them, they go to surgery, others they don't go, they leave the hemorrhage to resolve by its own. So it's something that is not clear up to date. So based on my experience, combining CT and MRI, if it's surgical, you will see it. If you don't see it, you can, like, if it's a jelly disc, yeah, it's surgical. Also that some colleagues, they don't go surgery. So for brachycephalic is not something that is a bit concerned. So the mineralized material, you don't see it easily, but you will do the myelo in cases that are borderline surgical. Thank you.
Do you think that surgical navigation can help in the needle positioning?
It could, but I think this tool is quite big for that application. So if you have it, you can use it, but I think for those cases, I had to train a lot before I started on the live animals. So I think if you are well trained and you know what you are going, it's not necessary to use other tools, but okay, to be honest, I think it's not time to play this game on the first time with no experience with myelo or fluoro to start with this procedure.
Thank you.
No more question?
Sorry, I apologise. A similar question to the brachys. Do you worry about conation with Cavalier King Charles's and Chiari?
The sport.
You mean that if you are able to catch it, or by myelo, or
Getting herniation.
yeah, but what is the question about?
Raised pressure.
Okay, no, I don't afraid about that. Okay, it could happen. I think there's a lot of people who are afraid of myelo applications for some reason, and okay, I had some bad reaction after myelos, some seizures, usually after cranial puncture, but I didn't have some big complication. This kind of herniation I never saw after myelo. So okay, so there are some degenerate, hereditable problems, but this I don't have after.